Welcome to The Bone, the podcast that goes deeper. Here we cut through the noise and get straight to the core of the issues that matter. From real stories to raw truths, we dive deep into the conversations that shape our world and challenge our thinking. We're not afraid to dig in and get to the marrow of it all. Whether it's life, culture, or business in sports medicine, we're here to break it down raw and real. No filters, no fluff, just to the bone. With your host, Shelby Dailey, we're getting to the bone. This is a clinically pressed, approved CEU podcast. Find the quiz to gain credit at clinicallypressed.org/courses. Clinically Pressed Company, making the complicated simple through results that give back. Find out more at clinicallypressed.org. Let's get started.
Well, welcome back to the Bone. Today we have Alex Dailey, the Daily Double today. A few extra letters in his Daily though, but today I have Alex on to talk about musculoskeletal disorders, if that's correct. It goes by a few other names, but if we're going by the literature, this is the way that you find more information on it. So me and Alex connected through LinkedIn. Alex, what made you reach out to me?
So, Shelby, you had some very interesting posts on LinkedIn just about the athletic training profession and how we want to see it grow and improve. And there's areas I'm like, okay, this resonates with me, and I agree with this. So that's kind of how I wanted to reach out. And I had this idea, and I hope to potentially run with it because I think it's a potential avenue that athletic trainers can continue to see growth in, and most importantly, be able to see growth, improved healthcare for our patients, and hopefully it can spread to just beyond athletic training.
Yeah. So Alex's background, he's in Michigan right now. I'm sure it's cold this time of year normally, where everywhere else we seem to be freaking out with the weather. He's at Michigan State University as a certified athletic trainer who serves club sports, intramurals, and the general student population. So he specializes in movement assessments, manual medicine, and rehabilitation. So basically athletic trainer, but it seems like it's a little bit more, not narrow, I guess, but focused oriented. Is that correct?
Yes. So I really like this position because you get to dabble in a few different aspects. Like I'm at a university. I'm at my alma mater, Michigan State. So being in the university setting, has its own perks and benefits. It's not collegiate athletics. So you don't have coaches breathing down your neck, which is really nice. It is a little bit of, I wouldn't go full out Wild West like sometimes you run into secondary schools, but you kind of have a little bit of that autonomy, if that makes sense. But you're also serving, people who might not have access to healthcare or who might not be introduced to what an athletic trainer even is. So having a point person to get evaluated and then to figure out, like, do you need to see a physician, or like, oh, if I see the athletic trainer and work with rehabilitation, I can get better. So it really is just a kind of a starting point to where you need to go in order to get better.
Yeah. Well, that was today. I just saw an article about new legislation in Iowa where they're looking to open it up for the school districts to hire athletic trainers as another option for the school nurses. Obviously, different scopes. It's quite a debate right now on that post, but it's very interesting. And I think that we are perfect fit ultimately because we are supposed to be there for the emergency care, when they get hurt. Maybe I just wasn't in the nurse's office as often, but it sounds like they deal with certain student populations a little bit more, which obviously we respect them for that too. But it's very interesting on where athletic trainers are starting to pop up and what skills we can actually provide.
Absolutely. I think you're spot on there. And I think I think as we continue to grow as a profession, I think you're going to see different settings continue to emerge. And I think that's exciting just for not our profession as a whole, but also for just patient care as a whole.
Yeah. So even though you're in the, I wouldn't say non-traditional, but not the classic athletic training role, what is your favorite thing about being an athletic trainer?
I say this every day. I have a chance to make a difference on someone else's life. And it can be as simple as, you're rehabilitating someone and they went from not being able to squat to I am able to squat now, or maybe you have a hamstring strain. I can only get to 60 degrees range of motion, but after working with the athletic trainer, I can get to like 80, 85, and I can start to do some more functional work, or whatever it may look like. Or I had a really crazy injury that less than 3 weeks into my time at MSU, where I had to refer the individual to the ER thinking it was acute appendicitis. And not only was it that, but it was a lot worse. And if I wasn't there for that person, I don't know if they would be alive today. So just the impact, you never know what's going to look like, but you always are there for them. And it's incredibly refreshing and rewarding.
Yeah, definitely. So, with the musculoskeletal disorder, I was calling it dysfunction, pain. There's a lot of different terms for what you're going to talk about today. What other terms are there out there that people may be getting confused with this
Sure.
literature term?
I think musculoskeletal pain, that was kind of the one that I ran into a bit. And then this is where I did additional digging. And then the U.S. Bone and Joint Initiative has like burdens of musculoskeletal diseases.
Mm.
And so that's where I'm like, oh, musculoskeletal disease. And then I try to cross-reference with some other literature, PubMed, etc. And musculoskeletal disorder seems to be the more professional term. So that's what I'm sticking with.
Okay. So, can you give us a little background on why you're interested in this and what the literature is telling us at the moment?
Absolutely. So it really started when I came back to Michigan State. I felt the volume of what I was seeing and the demand that we had was quite high. I'm like, this seems pretty high, and like this just seems like it just continues to grow. And every year I've been here at MSU in this role, I've seen the growth in the number of injuries evaluated, number of what I call patient contacts. So whenever I see someone for rehab or eval, the number of referrals to our overseeing physician group, MSU Sports Medicine, our um, just the number of different patients we serve as a whole. And each year we've been tracking it, and that number continues to grow. And like, okay, what does this look like in a national landscape? So honestly, the dive into the burden of musculoskeletal diseases was kind of that first iteration of seeing that, yes, this is not only is this a nationwide problem, but actually it's actually an international problem too. But I want to focus more within the U.S. because athletic trainers, we serve traditionally within the U.S. So let me pull up my notes. So based on the literature that I've seen, um, the U.S. Bone and Joint Initiative, the most recent update was like the data is from 2015. So I think there might be some more data coming soon that these numbers could be updated. But you're looking at anywhere from 124 to 126 million Americans over the age of 18 have some form of musculoskeletal disorder. So that's more than one every two individual. So what is musculoskeletal disorders? What does that look like? So you've got disorders of the spine. So you have low back pain, neck pain, etc. And traditionally, those are more of like cumulative trauma. Another category was traditional orthopedic injuries. So your sprains, your strains, your tendinopathies, your fractures. That plays a role in it. Arthritis, other rheumatic conditions as well. So RA, OA, gout, etc. cancer of the bone and connective tissue was, a much lesser subset. They also briefly mentioned like spinal deformities such as scoliosis. And I try to figure like, what's the magnitude? What's the number? What's like the number one malady within musculoskeletal disorders? And I've looked, and it looks like low back, neck, and chronic joint pain was the most common musculoskeletal disorder. And you're looking at, and it was roughly reported around 60-ish million, almost 66 million adults. So that seems to be kind of the most common type of musculoskeletal disorder. So it's not only is it, a massive number, but also consider that, if someone doesn't want to be healthy or someone's injured, they're not going to want to be physically active. We know the pitfalls of physical inactivity, and we'll get to that in a minute. But I just wanted to lay out that, this is a much bigger issue than people realize. And I also found, where's the next one? So, yeah, back and neck pain is the most common cause of disability. But also, it's more than like cardiovascular issues. It's more common than cancer. Like some of those other conditions that we look at, and we have considerable concerns, health concerns that we raise up, but we don't talk about musculoskeletal disorders enough. So, and being as athletic trainers, we're on the front lines of this. And I feel like we're kind of that fulcrum between, is someone going to be physically active, is going to be healthy and active, or are they hurt and they're not willing to be, or they're not going to be physically active. So it's a very hard, it's hard to, be there for someone, but also if someone doesn't have the access to an athletic trainer or a healthcare professional that can help with rehab, it's going to be really hard for them to get better. Yeah. So this needs to be circle. It's a vicious cycle that we just have to find a way to break. And I'm not going to say we're going to, fix every single issue, but if we can help improve the lives of, a portion or a subset and continuously chip away, I think that's a place to start for us.
So the disorder is really a very wide net of different conditions or injuries ultimately. And so what you've been kind of looking into is how do we interject ourselves to help decrease that prevalence, and also to help keep people healthy through not falling into not being active due to pain or dysfunction, or so that it goes down a different path. Is that what you're basically saying?
Absolutely, yes. That's a very good summary.
So since this is so common, what age group, where in life are we seeing these things kind of developing, and what are some of the predispositions that are causing these disorders?
Yes. So the data that I've been able to find is more 18 and older.
Okay.
That's traditionally what I've looked at. Could there be more? Could there be data on pediatrics? Absolutely. I just wasn't able to find that, unfortunately. You're seeing that, over the age of 65, it is even more common. So really, adults from 18 to 64 years of age is kind of what I've been looking at mostly. Okay. But yes, over the age of 65 is, I think you'll see the individuals that, are physically active, that they're healthy, their quality of life ends up being better, so that, when they're older, the risk of them having, an OA or an RA or some of the other musculoskeletal disorders we run into, their risk could be lower. So as us as athletic trainers, we're big on quality of life, and rehabbing someone not just because they want to get back to a game or get back to the activity they enjoy, but it's also like we got to look long term, and
Mhm.
that's kind of how I view this data and the information. And it would be great to see if they had, you know, pediatric data on this as well, because I'd be really curious to see, what percentage of pediatrics would fall in this category as well.
Yeah. Well, I know that they've always talked about the transition from collegiate athletes to regular life, and they're trying to learn nutritionally how to properly eat because they're not expending as much energy as they were, or their activity has decreased so much that they're not really as active as their bodies used to. um, I was wondering, are they capturing any data of post collegiate or athletic careers with injuries, and maybe, I don't want to say it's a spiral, but the prevalence of possibly gaining weight or pain after they're done with their athletic careers?
So formally, I don't know. I've found that data yet.
Okay.
However, I have heard some anecdote information that data could be coming out in the near future that suggested that some the college athletes they sampled, maybe their quality of life might not be as good as an individual that maybe didn't do a college sport, or maybe
Mm-hmm.
they did a club sport. So their demands weren't as much like physically as versus the college athlete. Again, anecdotal. I don't know if and when that data would ever come out, but it is an interesting trend, and I do think with the NCAA they are starting to catch on to that, and I think they are trying to advocate health and well-being for the student athletes. So it'll be interesting to see if anything comes up, and what if there's any improvement, what that improvement looks like.
Yeah. And then I work in the hospital setting, and we have the joint replacement doctors that I work with. And looking at the population that comes through with joint replacements, obviously we see a wide variety of ex athletes or just older, overweight individuals. So, would you say that these interventions that athletic trainers could implement could possibly decrease the potential of having a joint replacement?
It's certainly possible. I think I'll give a good example. So like the hip, for instance, if someone doesn't have enough hip flexion and enough hip internal rotation, there could be a risk for potential labral issues in the hip, or even low back pain. And of course, if you're having that chronic wear and tear, that very well could lead to osteoarthritis down the line. So I could totally see that. You know, I want to see people move well, and I think that has to be an emphasis. And I think that's something us athletic trainers are actually really good at. And I think there's different pieces of evaluating movement that would allow us to understand how someone's moving, why they're having the issues they're having, and you know intervening to address those dysfunctions.
Yeah. So, how does this influence the broader healthcare system?
Sure. So I'll start with when patients are having a difficulty with musculoskeletal disorder, sometimes they don't have access to healthcare professionals that can provide rehab services. They might have a lack of means to getting to a healthcare professional. They might not have insurance, or they might be underinsured, or maybe they've seen a physician and maybe they were prescribed opioids, so helping mask the pain rather than address the underlying dysfunction. So from an individual standpoint, they can have they could go from ability to having some form of disability. So it might limit them being able to work. And work for some people could be as simple as sitting at a desk for work. Or if you have more manual or labor work, are you able to squat? Are you able to bend? Are you able to lift a certain amount of weight? So, you know, that work, that ability to work could be, undermined, and just the overall quality of life and loss of, just general independence. So being able to do activities, daily living. So it can start really small, but it can just spread into other aspects of your life. And, you're not going to be able to do what you love, what you enjoy. You can have an increased dependence on, you know, non-beneficial ways of coping with pain.
Mm-hmm.
Opioid, we know of the opioid epidemic, especially. And, just because it's one person, it can cumulatively you can have a cumulative effect if you have multiple individuals, and it just affects the healthcare system. So it's a strain on the healthcare system. You're putting in so many resources to get people better, focusing more on the back end rather on the front end. Does that make sense?
Mm-hmm.
Yeah.
Have you seen any research addressing the limitations that medical insurance has on preventative care?
I actually haven't.
Okay.
I will admit, I think that's an area that I would love to see a future growth and need for research. And if there are people who have found it, please let me know. I'm curious because I feel our country needs more preventative care, or, I don't know if preventative is maybe the correct term, but if there's ways to reduce the risk of injury or re-injury, I think
Mm-hmm.
that might be the more correct or accurate term.
Yeah, maybe like a health maintenance plan or something like that.
Yes, I like that.
I just would think that they would make more money because health maintenance, you would have to have more contact points. And uh, obviously, they'd have to pay out some premium to it. But doing that, I feel, would add up to the amount of a full blown joint replacement or some sort of major surgery over a period of time. Uh, that's working in the hospital. I mean, we have people coming in for well, you have two knees, you got two hips. Sometimes they come in and do a partial, sometimes they get the full, and then sometimes they're redoing it. So, I mean, the cost to the insurance company to manage that many surgeries, I would think that would work out of buying a gym membership or a dietitian or going to get a massage or whatever it needs to be to help somebody manage pain and hopefully get out of it. But, there's all those theories about big pharma and all that. So we won't get into that today, obviously. But going into this health maintenance, where do you see that athletic trainers need to be, or how can they help facilitate this better?
Sure. So, our main domains as athletic trainers is injury risk reduction, clinical evaluation, diagnosis, critical incident management, therapeutic intervention, so rehabilitation, treatment of orthopedic injuries, and also the professional responsibility as well. So I feel our injury risk reduction piece can be something that can be highlighted. Our clinical evaluation diagnosis is a nice piece as well. And I
Mm-hmm.
want to emphasize, when we look at clinical evaluation diagnosis, I think we often talk about like special tests, manual muscle tests, which are great in itself. But I also believe exercise ends up being a fantastic uh, evaluation piece, to be like, okay, let's see how you squat, let's see how you lunge, and break it down from there. And I think there's some really there's some exceptional benefit of that, and it
Mm-hmm.
tells, especially if someone's able to reproduce their symptoms based on whatever movement, it gives you information of how you could address it. In the therapeutic intervention, our rehab component, the demands of rehab especially with musculoskeletal disorders, just continues to rise. And I want to make sure we, are able to be there to help bridge that. And I know physical therapists can play a role in that as well. And then occupational therapists with the hand and wrists can play a role there as well. But I feel as athletic trainers, we could be in potential forefront in this.
Yeah. Do you do you feel that we are better situated for it than a physical therapist or an occupational therapist, or do you feel like it's just coming together and providing more care ultimately?
Sure. I think coming together is probably the more appropriate term. I think athletic trainers might be slightly suited more effectively just because we're used to working with people throughout, all the way up to, back to activity.
Mm-hmm.
But also I look at, athletic trainers in the secondary schools, or even like my position in rec sports, individuals that might not have access to healthcare or limited access to healthcare, and being the initial person to see, the first healthcare professional they get to see, being a point of contact. I think that's extremely valuable too, and I think that needs to be highlighted moving forward.
Yeah. Well, and I see it as the nice thing, or the what's the word I'm thinking of? The special thing about athletic training is that we aren't limited on time due to insurance or a tight schedule in a clinic. They can come in multiple days a week. Technically, they have quite free access to us. Sometimes it bites us in the butts, but I don't think that athletes take advantage of that enough sometimes, of the free healthcare that they're basically getting. So it's very interesting on that aspect of it.
Yeah, I want to add a point to that. I've had a couple patients in where I'm at right now. They were international students, and they have a hard time getting, having the means, having the access to physical therapy or rehabilitation services. So with having athletic trainers on campus here being able to have access to us, they've even mentioned that, like, I don't know if I would have been able to get this if I didn't have you guys here. So like to that point, being there for someone, and especially if they don't have access to the resources they need, they may not be progressing in rehab as quickly as you would hope for, or what you would assume within like a physical therapy clinic, because you would have insurance having to, you have to have certain requirements in order to get, more visits, but that's not how we operate. And I think from that perspective, it is nice to have, because kids have, knock on wood, they haven't exactly taken advantage of it in my setting. I've seen it only be a real benefit to them. And I've had multiple people tell me, like, if you had to bill for insurance for your bit, for what you do, I wouldn't come. And I've heard that numerous times from the patients I've served.
Yeah. Well, and it's that insurance dictates what is 100%. I've always said that with ACL rehab, they get you back to the 100% that you were at, but that 100% wasn't good enough for your body mechanics because you got hurt. You tore your ACL basically, obviously, if it was non contact. So we need to get you above that 100% so that your body can protect and stabilize that joint better. So it's very interesting on how we treat the human body and what our expectations are from outside sources.
Yeah.
Okay, so with this access of care, we already kind of touched on it, but outcomes wise, is there data that supports this at all?
Unfortunately, I haven't been able to find this as much. I know anecdotally, I've seen people progress that if they only had, so many visits at a time. I think us as athletic trainers, an area that we can improve in is having the data to back up, like, hey, yes, someone's been cleared, but like, what are some of the ways that we got someone to improve? Did we
Mm-hmm.
see improvements in their ankle dorsiflexion? Did we see improvements in knee extension strength? Did we see improvements with whatever you wish to evaluate? I think that needs to, I think more of the outcome data needs to come into the forefront for us to show our value and worth. And
Mm-hmm.
that will take time, and it's not easy. And I know some settings it's easier than others, but that's an area for growth for us.
Yeah. I've always thought it's interesting that we do all these in classic athletic training in collegiate or high school. We do all this fitness testing, and it's supposed to be a measure of where you're at and if you actually did your summer workouts or not. But from a healthcare perspective, it's always been interesting that we don't necessarily get to hold people back if they're not meeting the thresholds that were set for them. I always thought it was kind of a predisposition that they're at higher risk of getting injured because they aren't at the level that they should be. And I'm not sure if it would be us, strength and conditioning. I mean, we kind of hold the power with the pre participation exams because we go through them. But trying to catch these disorders and stuff, you would think that we would hold some of these athletes back, make sure that they get conditioned, and then return them back as necessary. And, this is a niche market of athletes, but in general, if a unfit person or somebody with a already pre-existing disorder came in, I think athletic trainers are really good at placing them in their ability level and creating exercises or programming off of that. So I don't know what you think about that, but that's always been something that's rolled around my head when we're doing PPEs is, I mean, I just created myself a bunch more work because this like 5 kids on the team couldn't do, the minute mile or whatever. But yeah, they're going to go into this 2-week hell week and kill their hamstrings or their quad, and then I'm going to have to deal with it. And then they have a pre-existing injury that's going to stick with them the rest of their life, basically. So just an interesting aspect, ultimately, I think.
Yeah, I think I agree with you, Shelby. I think almost having like a movement assessment, being able to assess, reassess, could be beneficial for us. In that way,
Mm-hmm.
Based on the movement assessment, could you see something that really, for lack of a better term, just punches you in the face? Like, oh, that's a very obvious, concern that we have to address. Great example. For instance, like a step down, for instance, if someone doesn't have enough ankle dorsiflexion. Well, that tells me that, okay, this is an area I want to address. So
Yeah.
that's to me where I'd love to see the shift for athletic trainers. And I think we can slowly but surely, I think we can see like, oh, we improved on squat, we improved on lunge, we improved on, whatever metric, whatever test, whatever exercise we want to use. And I think that can give us the ability to improve not just how we are viewed as athletic trainers, but how patients can see their growth. Because a lot of times patients, they'll buy in if they're like, hey, I saw improvement from, this session to this session because I was able to do this better. Like, having that anecdotal information is nice to have over time, and then it can help build our case moving forward.
Yeah. While we're talking about athletic trainers, how do we address with the third party reimbursement, like you had said? How do we get more people in the door to see us, or you know, I don't. Is third party reimbursement holding us back ultimately?
think it really depends on the setting you're in. Because third-party reimbursement, especially if you're like in a physician clinic, I believe, Shelby, is that your line of work, you work within
The outpatient at the
outpatient.
hospital. Yep.
So, that type of setting, it may make more sense. I know in my line of work, I've asked people in the past, and many of them have expressed that I don't think it would be, I think it would turn them away. So I think we'd have to be careful where it be introduced. I think the idea, if it's done correctly, is of benefit. I just am careful about how it's introduced, how you would go about doing it. So I feel like there's more questions than answers right now.
Yeah. So, looking at the future, what would be the best setup to get athletic trainers out into the public to be able to address these disorders?
Sure. I think what we're seeing right now, I guess maybe emerging settings, continuing to find these emergent settings. So you're seeing the industrial settings, seeing incredible growth. You're seeing, the performing arts, military, etc. Oddly enough, I actually would think maybe like your urban, almost, almost like in the city, like inner city, would make sense. I think you could see some benefits there. Athletic trainers, maybe if you have, I don't know if urgent care is the correct term, but having a clinic where you have a nurse, where like a nurse and an athletic trainer, where the nurse can serve a lot of the general medical, the athletic trainer can serve a lot of the orthopedic issues, and that way, having that clinic might be a place to start. Could you have it in your in the urban areas, the inner city? Do we look at the rural areas, because those are areas that feel they're not always served the way they should be? I think those are just different pieces we should look at and consider in the future.
Yeah. So, going back to the definition of the disorder, so as an athletic trainer, we know that we can do a functional assessment and like an FMS or whatever. They can do it, but they're not necessarily presenting subjective symptoms such as pain or tightness or any of that. But we can visually see restrictions or the inability to do the full motion. So, should we start doing more comprehensive PPEs in classic athletic training? And then secondly, should we start pushing for this type of evaluation in the primary care setting? Or do we go and partner with doctors and help with these evaluations? Because whenever I go to the doctor with my primary care, they always seem to ask, well, what's going on with you? What are you feeling? What are your problems? Tell me. And then they basically refer out from there. But they don't necessarily do any objective evaluations other than like blood pressure, respiration, those type of things. So, do you think that's an avenue of getting into the hospitals and actually doing functional evaluations, or would that be too much? I mean, we see so many people in a day. I have no idea how to logistically be able to touch on that.
Sure. Oh boy, that's a
Open the
loaded
can of
question.
worms.
It is a loaded question. I think there's two ways we can look at it. I think first and foremost, whatever injury that presents itself, I think you should consider, maybe let's take a lower extremity injury, for instance, like patellar tendonitis.
Mm-hmm.
One thing I like to look at, I like to see their ankle mobility. So the ankle clearing test, that's I believe it's the FMS. It was created by the same people who created the FMS.
Yeah.
And it's a nice, efficient test to be able to see, do you have enough ankle mobility or not? And then in a lot of cases I've ran into, like patellar tendonitis, or pain, someone's got pain in their knee, I found out that their ankle clearing test, they're not able to get the ankle dorsiflexion they need. And then theoretically, you can look at it, not enough ankle dorsiflexion, knee can't get over the toe, quads don't load as much as they should, patellar tendon probably gets more stress through it than you would expect, and so on and so forth. So I think if you could like regionalize it and do like a couple of fairly quick exercise, I don't know if exercises, but almost like clearing tests just to see, okay, can I see how you move? And again, it doesn't have to be the full FMS battery, but maybe a couple of more region specific ideas based on where you're looking. That might be a place to start and be like, oh, you might have patellar tendonitis, but really you've got ankle mobility issues that's could be contributing to it.
Yeah.
So I think that might give us an opportunity to help us. And it's still, if you only have one or two, maybe 3 tests, but it's something that's fairly quick and efficient to give you some information. Be like, okay, yes, you have this issue, but I think we have found out what could be contributing to it. That might give you an opportunity to not only show what we're able to do as athletic trainers, but also be able to just show the patient like, this is an area that you need to improve in. And also that gives them be like, oh, I wasn't able to do this before, but after doing rehab, I was able to do this motion again. I was able to see improvement. That also just gives not only the buy-in, but also shows like, okay, like this is what I need to do to get better. So and especially like if you're able to do it a couple weeks later, if you see the physician again, it's like, oh, you improved on that. Great, fantastic. So I think those are some objective ways that we as athletic trainers, we can do it with. You could do it with PPEs. If you see, you go through your physical exam, but you find a couple areas that could be better. Okay. So I know, so maybe I saw on that PPE, maybe they had some low back discomfort. Maybe they had, hip issues. So that way you can say like, okay, now you've talked about those areas that you need improvement. What are some ways that we can show that improvement? So I think that could be an avenue for us moving forward.
Yeah. And then working with other providers, that's where I asked, like, is the hospital the best setting to kind of get into? But I mean, it's almost revolving door there. I don't know if you could fit that in there most of the time unless you were a provider on your own just to do an evaluation, and like they do the pre-surgical exam where they do the blood testing to make sure you're going to survive the surgery. I feel like sometimes they almost need to do a functional exam other than the orthopedic special tests. So I think it would help outcomes ultimately if surgical intervention is needed. Yeah, going down the rabbit hole, I guess. But with working with these other specialties, how can we present this to them, and how do we get this to be a piece of care?
Sure. So I will say in my setting, when we refer people to our overseeing physician group, MSU Sports Medicine. So usually we write up a note, and we do it in a manner that's HIPAA compliant, etc. But sometimes we add in the pieces that maybe let's say if we have someone with low back pain, we're concerned about potential disc herniation, can have like the active straight leg raise. So I feel like there are ways that we can word not only how we send referrals, but and also in our conversations with physicians, with other healthcare providers, to demonstrate that like, here's areas that they've shown that they need improvement, and how that can be directly correlated to, the pain they're experiencing. Does that help?
Mm-hmm. Yeah. And then we already talked about expanding the role, and then with RFK's health initiatives that are going on, we'll see how far he takes it or what all he can actually do. How do you see athletic trainers fitting into this new health movement that's coming in?
Sure. So first off, I think we've discussed at length that musculoskeletal disorders place considerable demand and stress on not only just the population, the patient population whole, but also the healthcare system. So I think as athletic trainers, our demand will just continue to grow. So with our 5 realms of athletic training, we're going. I feel the injury risk reduction piece will be big. I think the clinical evaluation diagnosis will be incredibly beneficial. Yes, critical incident management can play a role in certain cases, but I think our therapeutic intervention, our rehab piece, will be massive because the demands are just astronomical. Like, I even looked internationally to see like what's demand internationally, and I think I read somewhere in 2021 the demands for rehabilitation throughout the world exceeded over 1 billion people. And I could be wrong, but this demand just continues to grow, and it's throughout the world. And having an athletic trainer to, like, we're used to working with volume. We're used to working with demand, and having an individual as your point person in the healthcare system, you can evaluate someone. You can find ways to reduce the risk of injury or re-injury. How can you rehabilitate the individual? And also, maybe it's a case where you have to refer out, but you have a referral partner you work with. I think it validates what we do. Not only our exceptional patient care, but also the experience people can come see us. Rather than having to wait a certain amount of time to see somebody, you can see it instead of starting at the top of the pyramid for healthcare and work your way to the bottom. Why don't you start at the base? Because if you start at the base, you can know that I'm at a spot, and if I need more help, I can go further up. But in several cases, in what we do, they may not need to go all the way up to see a physician. Like, if it's a lateral ankle sprain, I mean, I might refer them to a physician to make sure there isn't a fracture. But beyond that, like, they can do rehab with us. Our overseeing physician group, MSU Sports Medicine, like, if they evaluate someone, they're like, yeah, it's not surgical, but I still think you need rehab. A lot of times they even say, like, if you want to see the athletic trainers in rec sports, you're perfectly fine in doing so. And they have that trust. And I think building that trust in healthcare is gonna help athletic trainers as a whole. And I think you asked the question, like, because we're, traditionally athletic trainers are overseen by a physician. And I think you asked, like, do we break away from that? I think physical therapists have.
Mm-hmm.
I think there's a double-edged sword to that. I think on one hand, it would be nice to have that autonomy, but also I think there's an increased risk for litigation, because if you don't have another set of eyes and you miss something, it's on you. So
Yeah.
having the physician oversight is not, at times, is extremely beneficial. Like, if you have an injury or you have a condition that you're evaluating, like, hey, I can't make sense of this and I need someone else to take a look at it. I think that's really what, having a physician, being there for you is helpful. So I think how we're structured as a healthcare profession just shows how we can be committed to the patients we serve and making a difference in their lives. And it varies depending on setting, and varies depending on resources that they have. And I think you're just going to continue to see that. Now, how can we market that, and how can we help with, work-life balance? How can we, make the salary, better? Those are questions that, we can continue to talk about moving forward.
Yeah. Do you think it needs to be a mindset shift to be able to integrate ourselves into these different areas to be able to accomplish this, addressing these problems?
I would love to say yes, but I also know there's only so many athletic trainers, and you can think about all the different areas that you could see where, like, oh, I want to see them in this setting, or I want to see them in this setting, or I want to see every athletic trainer in a high school. So I think we need to be mindful of also, yes, we want to make sure, everyone that needs to get seen gets to be seen, but how can we do it with the resources at our disposal? And, if there's settings that make the most sense, do we look at pursuing them more? So
Yeah.
I think there's a lot of questions for people that are above my pay, that I think a lot of these questions are above my pay grade, but I think there are questions that we can at least discuss and figure out and brainstorm together.
Yeah. I've seen a lot of athletic trainers start integrating into gym settings and trying to do the evaluation to help prepare a program for them or the patient in the gym, which I think is interesting. I wonder, with this musculoskeletal dysfunction, obviously I've worked primarily with athletes. Now I'm in the hospital settings, so I'm kind of seeing this longevity of people, the ex-athletes that are, in their 40s and stuff now. And in the athletic setting, we have specialized skills to keep the athlete going, even past probably what the body should withhold, or withhold, with yeah should endure. And I think it's interesting that athletes are the epitome of health, but we're at a time and culture where you're supposed to push past this threshold ultimately. So I think it's a interesting paradigm to look at, and I'm all for great sports and performance, but I think for some athletic trainers, I think we could fit into that overall life health, the health maintenance that we had talked about. I think it would be easier ultimately too, because obviously recovery is still very important, but it doesn't have to be so extreme, and there's a little bit less on the line ultimately. That's
Yeah,
my kind of impression on it.
I think I agree. Now, how does that look moving forward? Remains to be seen.
Yeah.
But I agree. I think there's some benefits and some pluses on the horizon for us.
Yeah. Well, what else did you have from what you've been looking into on these disorders? Sorry, I was going to say dysfunction. It's disorders.
Sure. So I think one thing you asked me about, how can athletic trainers contribute to reducing the overall healthcare costs associated with musculoskeletal disorders? So we look, a lot of times we talk about like an injury like patellar tendonitis. We talk about rotator cuff tendonitis or a slap tear. And I think us as athletic trainers, I think we're caught up in that terminology rather than why are they having the injury? Like what's going on with the injury? So is it because they're not able to, when they lift their arm into flexion, their scapula doesn't want to move the way it should?
Mhm.
Does do they not have enough ankle dorsiflexion so they can't, get into a full squat? Do they have limited hip mobility, like to be able to squat or be able to do other functional tasks? So to me, I think we need to address more of the mobility, the stability, or even the strength concerns that lead them into the pain they're in.
Mm-hmm.
And I feel like us as athletic trainers, we have the tools to be able to address the underlying problem. And I think that's what I think us as athletic trainers, we bring to the healthcare system. I think that's something we can bring in. But not only that, I think that will help it doesn't just help the patients. It helps, patients feel better. They're able to be physically active. That's less of a burden on the healthcare system. So in theory, that should hope to lower costs in the future, rather than you're doing rehab, rather than having to do surgery or a hip replacement or something to that effect. So I think that if we shift our focus from being so treatment based rather than to be more, risk reduction, health and well-being, I think that will give us our most bang for our buck.
Yeah. We live in a very reactive healthcare system. So I think we need to start being more vocal about I don't like the word prevention. We need to find a better word, I think, to market ourselves. Haven't figured it out yet, but...
So to your point, Shelby, I think risk reduction might be a better term.
Yeah, I think that you said that earlier, and I was like, I think that's good. I still think there may be something a little bit better, but we'll figure it out along the way.
And I'm okay with that. A lot of times when we brainstorm and we come up with ideas, that's where you bounce ideas off one another, see what sticks, and you talk to other individuals. They might come from a perspective that you're not accustomed to. So exactly. I'm with you. Yeah, this is just because you have a conversation doesn't mean the conversation at the end. I hope it's the start of more conversation, discussion in the future. Yeah.
Well, that's the point of this podcast, is to get ideas out there so people can start, stewing on it and figuring out if it's something of potential. So how can people contact you if they want to talk more about this?
Sure. I think the best way will be my email. So Dailey AL, so D as in David, AILEY AL @msu.edu. That's probably the best way to get a hold of me.
Great. And then is there anywhere they can follow you? Are you posting any of this information anywhere?
So not yet. This talk about musculoskeletal disorder, I'm hoping to do a TEDx talk at MSU.
Oh, awesome.
Hopefully I'll know on Tuesday if my application gets accepted or not. But I think educating the general public on information such as this is a good way to grow our profession. More importantly, grow patient care as well.
Definitely. Well, keep us posted on that. And if it's recorded, I'll put up a link for everybody to watch.
Thank you, Shelby. Thank you for your time.
Yeah, thank you for coming on.
Have a wonderful day.
You too.
Bye.
That's it for today's episode of To The Bone. I hope we've sparked some new thoughts, challenged your perspectives, or simply reminded you to dig a little deeper. Remember, life isn't just about what's on the surface. Sometimes you've got to cut deeper and get to the bone of what really matters. To The Bone podcast is a product of Dailey LLC. It's hosted and produced by Shelby Dailey, ATC, and Randy Dailey. No clinical decision-making should be based solely on one source. While care is taken to ensure accuracy, factual errors can be present. For more on the show, visit www.tothebonepodcast.com. If you enjoyed this episode, be sure to subscribe, rate, and leave a review. Get involved in the conversation. You can find us at www.tothebonepodcast.com. Drop us topic suggestions or be a potential guest. We're all about connecting with you, our listeners. Until next time, stay curious, stay grounded, and keep cutting deep.